So, hello everyone, welcome to the RadioCure lecture series. So, basically, today we are starting our first class on this RadioCure lecture series, and the first topic I will start with the RadioCure, with the radiopharmaceutical, because I think radiopharmaceutical probably the first thing what the people are thinking when people are thinking about nuclear medicine. Radiopharmaceutical is the first thing they should know of. Otherwise, they can't. I think they can't plan anything because everything in nuclear medicine starts with pharmaceutical. When we are injecting it in body and we are doing some type of imaging study or therapy study. So whenever we are doing something, it starts with radiopharmaceutical. I think I'm audible. Anyone can confirm?
Yes, sir.
Thank you. So today's topic, I will basically describe in the radiopharmaceutical lecture series what I will cover, what will be the syllabus, and little bit basic idea about the nuclear medicine and radiopharmaceutical and the clinical perspective of it. So basically today is a first class and it's a basic class. So to start with, in the part one syllabus, we will basically describe why nuclear imaging and radiotherapy. So today our topic will be why nuclear imaging and radiotherapy, and after that the topics will be different. So what are the other topics we will cover? In each class we will cover one topic. The second topic will be a short history of nuclear medicine and a basic nuclear chemistry and radiochemistry. Probably these two topics will be covered together in the second class. In the third class, we will describe methods for production of radionuclides for medicine, basically medical cyclotron, and how the radionuclides are prepared in various reactors or some generators. All those things will be described in that class. Then an overview of targeted radiotherapy, because how the targeted radiotherapy means targeted nuclear medicine therapy. So whatever nuclear medicine therapy is there, so a basic overview and an overview of nuclear imaging. Then will be describe the small molecule as radiopharmaceutical vectors. Then we will start describing an immunoglobulin as radiopharmaceutical vectors, because nowadays radioimmunotherapy it's going to be okay, someone is joining. So nowadays radioimmunotherapy is also a very hot sector. So some Bexar, Zevalin, all those things are there. They are injecting. So that will be described in those class. And nanoparticle as a radiopharmaceutical vector. So in the part one of our syllabus, we will cover in probably 5 to 6 class. We will cover all those things, and those we have named as the first principles, because whenever we will study anything, there should have some principle, and those are all coming under the principal part. And then we'll go to our next syllabus part 2. And I don't think I will cover all those radiopharmaceutical part, because there are other experts also who can contribute. If they are not available, then I will take the classes. But I think we will decide, because Sankladi is here. Sankladi is now doing PhD outside India, and he is specifically working on alpha emitting radionuclides and radiopharmaceutical therapy, all those things. So she can take some classes on that. So in the syllabus of part 2 of radio, we will describe mainly the radiochemistry, and this is a huge part. So in the first class, we will describe the carbon radiochemistry, carbon 11, which is a radioactive radionuclide of carbon. Then in the next class, we will describe on the nitrogen 13 and oxygen 15, and what are the clinical applications, how the radiochemistry comes. So all those things will be described on those class. And then we will go to the gallium and indium part. We all know gallium 68 is a very important, maybe in workforce in PSMA. So we will describe that. Who do not know about PSMA, endocrine tumors, we will describe in later on. Then we'll come with the fluorine 18, nucleophilic fluorination, nucleophilic and electrophilic fluorination we'll cover in probably 1 or 2 class of fluorine 18, because fluorine 18 we know for PET CT, positron emission tomography scans. The fluorine 18 is the, single hero, we can say. Maybe 80 to 90% scan in PET CT all over the world is done by fluorine 18 FDG scan. So that may not be covered in one single class. Maybe we need two class for nucleophilic fluorination and electrophilic fluorination. I will not cover the PET-CT. I will not cover the spec. That will be covered by Kaushik is here. Kaushik will take some classes on PET-CT probably after 14th of this month. And Raju Dai is here. Suraj Dai is here. They can take some classes on PET-CT, spec, those scans. I will specifically describe on the chemistry part, radiopharmaceutical part. And then we will go to the next generation fluorination. So that will also a very interesting topic. When we will come, we can understand how interesting the chemistry is, how interesting the biological interaction of those like radiopharmaceuticals. We'll come to know in those sectors. And it's not finished here because there is technetium 99M. Like fluorinating is the workhorse of PET-CT. Technetium 99M is the workhorse of, we all know, SPECT, single photon emission computer tomography. So technetium 99M also may not be covered in one single class, or maybe it can be covered. We'll see what we can do. And then we'll go to the copper. But as per my knowledge, copper will not be much of interest for the nuclear medicine facility, because whatever copper gives us, some other radionuclides are there who gives more specific than copper. We'll describe when we come to that topic. But okay, we'll study that. We'll study the radioisotope of copper, the radiopharmaceutical chemistry. Then lutetium and yttrium. Lutetium and yttrium probably one of the best therapeutic agent. Yttrium is used in hepatocellular carcinoma. The TheraSphere, SARSphere, in there yttrium is used, and lutetium. Lutetium is there, and also I will not cover here. Or maybe I can cover because holmium is also in this range. Lutetium, yttrium, holmium, samarium, all those actually comes under the lanthanide series. When we go to the periodic table, there we can see the lanthanide and actinide series. So in the lanthanide series, those comes lutetium, yttrium, samarium, and the holmium. And holmium is going to be probably one of the best therapeutic agent in near future. And I specifically am working on in my PhD on holmium. So probably I will take another specific class on holmium and their probable utilization in nuclear medicine in future. Then we will come to the zirconium-89, which is also not so widely used, but okay, we'll study. And then, of course, the iodine, radioisotope of iodine, iodine 123, 131, 125. They are specific applications in the nuclear medicine. So that will be a very interesting topic. After that, we'll maybe Sankladi can describe the alpha emitting radionuclide. If she is not available, then I will cover that. The alpha emitting radionuclide, like some radionuclide actinium is there, some other radionuclides are there who is actually emitting the alpha. Alpha means 2 helium 4 plus. So that we will describe, and then radiopharmaceutical chemistry of seldom used radionuclides in nuclear medicine. So all those things we will describe in the one by one class, because we can see like last 3 slide I have shown only the topics, and this slide also the topics. So each topic I have written, maybe it will take one class, maybe 2 topics can be covered in one class, but that will be very less. So you can understand how many classes will be there, and I will take around 40-45 minute classes in each and every day. So in the last part, there are some special topics are there for especially for the chemist backgrounds students, like bioconjugation method in radiopharmaceutical chemistry, click chemistry, what got Nobel in the recently. So in chemistry, so the click chemistry, and that has a huge implication in the radiopharmaceutical chemistry. So that we will describe. And equipment and instrument for radiopharmaceutical chemistry. When we are dealing with radiopharmaceuticals, we need some equipment, we need some instrument, we need some characterization techniques also. That will be described in this part. Then kinetic modeling of radiation. Whenever we are injecting something, how its kinetic is affecting our body, how its kinetic is affecting the biology of our body, the ecosystem of our body. So those things will be described here. Mainly the radiokinetics or the pharmacokinetics will be described. Then we'll describe a topic of choosing a target for nuclear imaging or targeted radiotherapy. So how we choose a target? What are the specific characteristics of a target to be potential target in nuclear imaging or targeted radiotherapy? That will be described in one class. And the last I will describe on drug target identification, lead discovery and optimization. And if time permits, I will also describe how the cancer drugs are formed, drug designing and drug development. Those will also be described if time permits. After all those things will be covered, then we will go to. So those are the specific topics, I think, and I think this should be in our head. So we can plan accordingly how to and in which class we'll come to know in which topic. So all those things should have a note, and I will share this slide also in our WhatsApp group and also in our Microsoft Teams. So coming to our today's topic, and this is a very small topic, why nuclear imaging and radiotherapy. So whoever is not very much familiar with nuclear medicine, probably we all are here, we all are familiar with nuclear medicine. But the general people, the chemistry background people, physics background people, they have no idea. Whenever we joined this course, we had no idea what is nuclear imaging, what is nuclear medicine, radiotherapy. So for them, this class is going to be very interesting. And I also think whoever is present here, they will also get a glimpse of what is nuclear medicine all about. So basically, we all know, at least whoever is present in this class, they all know what is nuclear medicine. So basically, nuclear medicine is classically defined as an application of radionuclides in medicine. So whenever the radiation term comes into our mind, we got a very fine image of the Hiroshima Nagasaki bomb blast. So, but actually, the radionuclides can cure us, and that's why we gave the name RadioCure in our lecture series. So radionuclide can cure us. It can help us to lead a better, a much more better life. And in that sector, in the health sector, radionuclides have many more to contribute, many more things to contribute. So, and this contribution happens in the name of nuclear medicine. So this sector actually specifically use two things. Radionuclides have two specific characteristics which the normal nuclides, oxygen, carbon, nitrogen, fluorine, whatever the normal, whatever we are eating, whatever we are breathing, they do not have that particular two properties. What is written here? One is half-life, and another is emission of particles or electromagnetic radiation. These two speciality of radioactive elements makes them so good for this imaging and therapeutic purpose of our body in vivo system. So I think this is basically the two factor which I have found, at least, that for which this sector emerged as a beautiful sector, as a most hot sector in what I can say in research. So what actually happens in radiopharmaceutical, there will be a radioactive nucleate, and that nucleate is this. So this is the radioactive nucleate, and that actually binded by a linker to a targeting molecule. What is a targeting molecule? In our body, maybe this is our body, this is a cell. Every cell, they actually shows some target protein in their surface, and depending on their characteristics, depending on that particular site's characteristics, the target protein varies. So whenever we are specifically targeting something, like if I want to target in some institution, I need to know in that institution who is the person who is going to talk with me, who is going to help me. So probably if I am going to go to AIIMS Nagpur, then I have to call Rajuda, and Rajuda is that target protein in AIIMS Nagpur, and this targeting molecule is me. But I am going to AIIMS Nagpur with some purpose, maybe to cure myself, maybe to do some deal with that organization, maybe to get some data from that organization. Whatever may be, that purpose we can define as the radioactive compound. This is the purpose, and this is me, and this is the particular person in that organization, and this is the organization, and here is the linker. Who is the linker? Now, my work. So why I need that why I have that particular purpose? That is the linker. So I think I made it very clear. So to make a radiopharmaceutical, we need to know to who we are targeting, and that particular targeting molecule should specifically bind perfectly with that targeted protein. Like Rajuda knows me very well, and that's why whenever I call him, he will pick up my call. But he will not pick up everyone's call. Maybe a spam call he will not pick up. So the person who has some work with that particular institution, he should know who is going to be targeted and who is the person who is passing that information to that organization. So these two things is very important. So here comes the drug delivery and drug modification and the kinetics part, lead modification, all those things comes in this, and those things will be described later on. And the linker and this radioactive element, they are specifically going to that particular organ by the help of this targeting molecule, and they are giving us some information which we need. So this is all about our radiopharmaceutical and how we get some information. Basically, nuclear medicine is an information bearing system. So what nuclear medicine is doing, they are giving us some information by which we can treat a patient, by which we can diagnose a patient, what happened to him or her. So this is the motto of this whole nuclear medicine facility. So now coming to the next slide. What is nuclear imaging? I have already told you what is nuclear imaging. Nuclear imaging is predicted on the fact that essentially none of the biomolecules in our body, they are radioactive. So in our body, no one is radioactive. So whenever we are injecting some radioactive element with some targeting molecule to some specific binder, then that radioactive element can give us some information, some imaging information with almost infinite contrast. What is infinite contrast? Now, whenever some person, maybe like in Caribbean, if anyone, okay, someone is joining again. So maybe just for understanding, in a world of black people, if some white people came, then we can identify that, okay, this person is not from here. This person is like something special. And even in the white people's area, if some dark people go, same thing will happen. They can be easily identified, and their contrast will be clearly visible to the other people, irrespective of the the position or the situation. So this is how, like here I am taking a black dot in the, and I am just making it. So in the white background, the black dot has almost infinite contrast. So in our body, there is nothing called radioactive as such. So whenever we are putting some radioactive, that can be identified so clearly that we will get our information like in infinite contrast, in like maybe we can say in super high resolution. And in nuclear imaging, we can get the real-time imaging that will be described later on. But what is real-time imaging? Now, whatever is happening in our body after injecting, we can continuously, like, we can see what is happening inside the body, how it is interacting with something in molecular level. Till now, the CT scan or the other scan, like MRI, they can't give us the real-time imaging, or they can give us the functional imaging. But by this, we can get the functional information. What is functional information? Like what is happening in our body, in which part of our body its temperature is high, in which part the glucose accumulation is high. So all this functional information we can't get from CT or MRI. But this nuclear imaging can give us those small information which will help the physician, which will help the nuclear medicine technologist, all the persons who are actually helping people to live better, healthier life. They will get to know what is actually happening within the body of the patient. So those small things actually makes it superior to other scans. And high quality image using very small like activity, 60, it will not be 60 to 600. The 30 to 600 megabecquerel, if we inject, depending on that person. So it will give us super high resolution image, and this 30 to 600 megabecquerel radionuclide actually consists of nanomole of compound. What's in nanomole of compound? Like if in our body there is so much like chromium is in our body, iodine is in our body. So whenever we are injecting iodine 131 to our body, that will be in nanomole range, and nanomole is so less that it will be like act as a tracer. Like we can't actually, it will actually not hamper the normal body function. So this is called the tracer principle, and this is proposed by Professor D. Hevesi, and what it's told that whatever we are injecting, the radionuclide behave as a true molecular tracers without perturbing the native biochemistry of the system. So it will do it work, but it will not hamper the biochemistry of that particular system. So this is how beautiful this imaging procedure is. So going to the next slide, what is nuclear radiotherapy? So I have already told you, those are the basic concept what we are describing today. It's not like I am going in depth, but just to show what is nuclear medicine and radiopharmaceutical all about. So why nuclear radiotherapy? Because till date, whenever we are giving a radiotherapy from outside our body, it can kill our body, normal cell also. But whenever we are giving nuclear radiotherapy, I have shown here the PSMA scan. So you can see in the PSMA scan here a person is affected by some carcinoma, and particularly prostate carcinoma. And whenever we are and probably neuroendocrine carcinoma, not prostate carcinoma. So whenever we are injecting them with lutetium PSMA, I am not describing what is PSMA, lutetium, all nothing is describing there. So I am just trying to say it will specifically go to that particular site, and it will actually kill the particular carcinoma, and it will go out of the body. So it will not affect our normal cell as it was affected previously. When we are giving the radiotherapy, we can't actually see the particular area. Whatever particular we are giving from outside the body, it will kill some of the normal cell. But in the nuclear radiotherapy, that will not happen. The side effect of nuclear radiotherapy is much less than the other radiotherapy processes. So this is a huge thing. So by nuclear medicine, not only we are getting nuclear imaging, but also we are getting a very good specific radiotherapy, which is helping that patient to have less side effect and live a better life. So ultimately, whatever we are doing because to give the patient a better life, a lead a healthier life. So that is the main motto of all the medical professionals, and we are specifically trying to do. So why nuclear medicine is a vis-a-vis alternative? Because see, nuclear medicine has no other alternative. This is a alternative of itself. Like if there is no nuclear medicine, then which can like be alternative of nuclear medicine? Nuclear medicine itself can become the alternative of nuclear medicine. Because there is no other alternative of nuclear medicine. Why? Because the greatest advantage over the forms of imaging and therapy is the molecularly sensitive. See, whenever we are taking an image, a normal, maybe a like anatomical image, then CT/MRI is good. But whenever we are taking an image in a molecular level, then we have to depend on the nuclear medicine only, because nuclear medicine specifically can target the glucose metabolism, receptor binding, and cellular transport. These three things are the sensitive, are the advantages of nuclear medicine. Nuclear medicine can target the metabolism, like glucose metabolism by fluorodeoxyglucose, receptor binding by neuroendocrine and steroid receptor, like we know the PSMA receptor, all those things, and the cellular transport, like amino acid transport in our body, that can be imaged. So those things can be imaged by nuclear medicine procedure. So now coming to the clinical application. So first we'll start with endocrine disorder. Okay, sorry, I think. No. The part I think we have missed out with something. So it will be cancer. It will not be endocrine disorder. It will be cancer. I just missed out it. So whatever. So imaging aberrant glucose metabolism, we can image by 18 FDG. We can image how the glucose metabolism is working in our body by fluorodeoxyglucose, 18F fluorodeoxyglucose, and we can do amino acid transport. We can see by imaging by 18 fluorine flucyclovine, so that we can use for particularly amino acid transport to see the amino acid transport that cannot be seen by CT image or MRI image. And if we want to see particularly the prostate specific membrane antigen or the neuroendocrine tumor, so the biomarkers we are using biomarkers imaging that is done by 18 fluorine and 68 gallium level small molecule ligands to target prostate specific membrane. Those are some examples I am giving, practical examples what actually happens in our like cancer. To detect the cancer, to treat the cancer, those are the very specific like pillars of nuclear medicine. And then we will know the imaging new bone formation by 99M technetium MDP or 18 fluorine sodium chloride. So those are some like MDP. MDP what can do? It actually diphosphonate. So diphosphonate actually targeting. I have told already to you that it actually target our body. So in our body part, the bone is there. So whenever we are targeting the bone, the diphosphonate actually target specifically to our bones, not other areas of our body, not other organs of our body. So by this way, we can use the FDG, we can use the flucyclovine, we can use the small molecule target labeled with gallium 68 or fluorine 18, and also we can use the technetium 99M MDP or 18 fluorine sodium chloride to actually know the cancer outcomes and to actually study the cancer outcomes. And here is the endocrine disorder. We can study with the endocrine disorder by 123 iodine sodium iodide. So how we can do that? That characterizing and quantifying the basis of hyperthyroidism. So whenever the hyperthyroidism happens, the patient the doctor refers the patient to the nuclear medicine center or the nuclear medicine department, and then we actually do the scan by 123 iodine, and sometimes it's the scan also done by 131 iodine also. Depends. Sometimes the scan also done with technetium, because technetium and iodine is mimicking each other. So that also have done some part technique also used. Whatever. So in the thyroid carcinoma or normal thyroid disorder, we use iodine 123 or technetium part technique and or 131 iodine. Those things is used. And whenever the abnormal catecholamine producing tumor is there, so we use 123 iodine MIBD scan to study that particular tumor. So those are the clinical applications of nuclear medicine in endocrine disorder. Just to give you an idea, all those things will be described later. The clinical application in cardiovascular disease. Okay, in cardiovascular disease, 99M technetium sestamib is used to identify the significant coronary artery disease on the basis. What is the mechanism? The mechanism is delivery of perfusion agent, which is retained in the myocardium. So in our body, the heart has the myocardium, and we are sending some perfusion agent, and those perfusion agents which are actually retained in the myocardium are imaged, and those are imaged by the 99M technetium. So those perfusion agents like sestamib, etc., are tagged with 99M technetium, which is our radiopharmaceutical, and that is how we can image those things. Or sometimes in earlier they used to use the 82 RB for also this type of image. And there is also another one cardiovascular disease imaging is there. We use 123 iodine MIBG here also to actually measure the aberrant parasympathetic cardiac intervention when the heart failure happens and arrhythmias. So all those terms actually can be described the professionals, whoever is actually in that particular field, whoever is actually scanning, or who are the physicians. But how those are targeted, that can be described in our class in the radiopharmaceutical. So those are for some examples just given to understand that okay, this is actually not in the paperwork, but also this is actually happening in practical. And in the nuclear radiotherapy, the 3 slide we came to know in the earlier, those are for the imaging purpose. And in the therapy, we also use the 131 iodine, because 131 iodine actually it emits beta. So whenever some radionuclide is emitting beta or alpha, those are called ionizing radiation, alpha, beta. So they are actually used for therapy purpose, because they actually breaks our DNA, double strand DNA, they breaks out, and they actually happens, some crossfire effect happens in that particular body part, and then the cancer actually killed. So in thyroid cancer, the 131 iodine is used, because iodine is normally iodine uptake is normal in our thyroid. So we use that idea to target and just kill that thyroid by mimicking iodine with 131 iodine, radioactive iodine. And we also use for bone metastasis, we use 153 samarium EDMP. This is also a diphosphonate, EDMP also a diphosphonate family chemical, and we actually target for bone, and the 153 samarium is also actually emitting the ionizing radiation, and that is how it actually kills. So whenever we are targeting technetium 99M with EDMP or normal MDP, then what is happening? The technetium 99M actually emitting the gamma, and whenever we are using that particular like MDP or EDMP with samarium 153, it is actually emitting the ionizing radiation. So whenever the ionizing radiation emitting radionuclide is attached with some targeted vector, then it's used as a therapeutic purpose. And whenever some like gamma emitter radionuclide is used, then that is using in imaging purpose. So there is a neuroendocrine tumor, and probably in last 5 to 6 years, this is a havoc development by nuclear medicine to treat PSMA patient, to treat neuroendocrine patient by targeting the somatostatin receptor and using once, like see, to image that PSMA or endocrine tumor, we are using gallium-68, which is a gamma emitter, and to target that particular PSMA patient or neuroendocrine tumor patient, we are using 177 lutetium. The targeting vector is same, but we are using 177 lutetium for killing that and 68 gallium for imaging that. And for hepatocellular carcinoma, the 90 yttrium therasphere is used. This is particularly a microsphere within which some yttrium 90 is incorporated, and we are actually by inject it by catheter to the particular liver, because liver is a very complex system. We can target by oral system to liver. So that's why we actually incorporate a catheter to particularly to the portal vein of that, the hepatic artery of the liver, and then we inject this type of microspheres to that particular space, and we actually kill that hepatocellular carcinoma by this therasphere. So by this, I am coming to a conclusion that what is nuclear medicine all about? What are the syllabus we are going to have in the next few months? So in each week we will probably take 1 or 2 classes, probably 1, because if every person start taking classes, then probably in each day we can't take a class. That will be difficult for the students also. So we will take probably 3 to 6 class, 3 to 4 class in each week. And coming to a conclusion, so a question is there: will other imaging or therapeutic approaches replace nuclear medicine? Will it ever happen that nuclear medicine will go down and some imaging or therapeutic approaches can replace it? So till date, whatever review paper is there, it's sure that no one can replace nuclear medicine. I also told earlier that nuclear medicine's alternative is nuclear medicine itself. So I have shown 2 pictures here why it's not replaceable, why we can't replace nuclear medicine. Because see, here we have shown some CT image of brain, but whenever that CT image comes with PET CT, positron emission tomography scan, then what is happening? We are getting the functional image. Never ever CT or MRI scan give us the functional image. We also described it earlier. So that is the main purpose, to understand or to like become a hero for nuclear medicine. Nuclear medicine is hero for that particular purpose. It's giving us that very fine, very high resolution, very specific, ultra high resolution images of functional property of a particular, maybe it brain, maybe it heart, maybe it's liver, whatever may be. That cannot be replaceable. So this is a clear shot. If anyone asks you or me or anyone in that field that is it replaceable? No, it's never ever replaceable. And also for the MRI image, here I have shown some MRI image of brain, and here I have shown some MRI image when it's actually tied up with nuclear medicine. Nuclear medicine, nuclear medicine itself can give a high resolution image. Actually, nuclear medicine gives the functional image. But whenever it's actually merged with the CT, like here, it's not only a PET scan, it's PET scan with CT. PET scan is merged with CT. So we are getting the functional and we are getting the anatomical. Anatomical imaging we are getting from the CT image, and functional image, the molecular level image, we are merging it with CT. And in MRI also, MRI we get soft tissue imaging. And in the soft tissue, if there is some molecular imaging is required, then we do the PET MRI. And then this is the only PET and this is the only MRI. And whenever we are merging these two, we are getting a super fine resolution PET MRI image, which is giving us a very good analytical image, which a physician can analyze and they can actually get something. So by this, the bottom line of today's presentation is nuclear medicine is application of radioactive element to medicine. Radiopharmaceuticals operate on the tracer principle, which I have described earlier, that it will never ever actually hamper the biochemistry of that particular organ of that particular cell. So the radiopharmaceutical operate on the tracer principle. This provides high sensitivity of molecular specificity. Radionuclide therapy provides a high targeted treatment modality based on physical impact of radiation. It is much more targeted than external beam radiotherapy. I have told already earlier that external beam radiotherapy actually kills the normal cell also. But in this nuclear medicine targeted therapy, the specification is much more higher than the external beam radiotherapy. So the side effect is much more lower. And the radiopharmaceutical provide a key link between the basic biology, the persons who knows the basic biology, and the person who is doing the clinical practice. That link is matched by the nuclear medicine persons. The future of nuclear medicine depends upon the ability of radiopharmaceutical chemists to leverage advances in molecular biology into new approaches of clinical imaging and therapy. So whenever the molecular biology will develop, the radiopharmaceutical chemists, the scientists, they will target much more specifically using the molecular biology knowledge. Then the radiopharmaceutical field will be like much more increased, much more specific it will be. And that is how we can get much more specific clinical image and much more specific therapy. So this is how we can utilize nuclear medicine. We can use radionuclides to help people live better, healthier lives. Thank you. If anyone has any question, you can have some question answer session also on those topics we have covered here. Otherwise, my presentation is over. Thank you all for staying here, for patient sharing. Any question? Thank you, Raju. Okay, so no one will have any question. Everyone will use the emoji. Okay, that's great. Okay, thank you then. Then good night. Okay. Good night. And the next class we will announce in our. Thank you.
Good night, sir.